So I go for the closest approximate protocol. So like, because I need to justify in case patient runs into trouble, dies because of the treatment, right? So I use for the closest approximate combination. Just because it does not respond outside the body does not mean it will not respond in the patient. But I found it a way when sometimes you have a gut feel that you feel that the patient's not going to respond, right? And in those settings, I've used the Optim.AI to suggest palliative care in those settings. Because this patient does not, sometimes, officially speaking, this is the next round you should be giving. And the patient is also asking for it. But, you look, the patient really doesn't look fit. You feel that, you're going to do him a lot more harm than good by giving more chemotherapy. Then I've used that in that particular setting. It's not a wrong thing to do. In fact, if you think about it, it's more cost-effective option for the patient. Less suffering, less money down the drain. Yeah.
It can help because if you show them the result and the possible predicted response to it, they would not easily consent, but they will be more cooperative with your plan. Yeah, it's a shared decision making.
I haven't had the need to justify to hospital board yet because some of the patients were ready to pay for the drugs anyway. I might write a name patient, name drug usage for some of the drugs. Like cladribine is kind of off-label in some instances too. So I haven't had to use it for the hospital board yet. But if I'm going to justify for subvention, if I'm going to have to justify someone else is having to pay, then in that case, I might have to do that. But I will find it useful. But I think as Optim.AI, Kayan gathers more experience, continues to publish, continues to gather registry data, gets our experience together and publish together with us, I think that would give us additional weight when we have to convince hospitals, insurers, and potentially even subsidies from the government and otherwise.